Hi, I am Dr. Rajeev Sharma. Today we will discuss important topic approach to abdominal pain. We should know the chronology whether it is acute or episodic. Acute pain might be because of bowel perforation, ruptured abdominal aortic aneurysm, or it could be because of myocardial infarction. Episodic pain, as the term suggests, it might be in episodes or intermittent like gastroesophageal reflux disease, biliary colic, angina and chronic mesenteric ischemia. Now location is very important as we have discussed in our last video. There are certain aggravating and relieving factors which we must know. Sometimes pain gets aggravated by taking meals in case of peptic ulcer disease. Also, food increases pain in pancreatitis as well as biliary colic. So positioning is very important. Which position actually aggravates and which actually relieve the pain. Activity, whether pain increases on activity or on rest. Now certain relieving factors, as in gastric outlet obstruction, abdominal pain gets relieved after vomiting. In pancreatitis, pain gets relieved by bending forwards or sitting and aggravated in supine position. Patient wants to get still in case of the peritonitis. Patient takes sometimes flex position in case of the colicky abdominal pain. Now associated features should also be looked out, such as nausea, vomiting, jaundice, fever, constipation, GI bleed as well as significant weight loss. Past medical history is also very important. You should take the history regarding diabetes, hypertension, coronary artery disease, COPD, that is chronic obstructive pulmonary disease, asthma, tuberculosis, then inflammatory bowel disease as well as cirrhosis. Menstrual history should be taken from the females. Then drug history is of very much importance, especially drug-induced gastritis. Like over-the-counter drugs, herbal medications causing the liver failure and IV drugs which can really lead to the hepatitis. Traveling history is very important, especially in cases of the loose motions. History should be taken regarding substance abuse such as alcohol and tobacco. Sexual transmitted disease history also should be taken in detail, as we all know that sexual mode of transmission is very important culprit in hepatitis. Physical examination you should do like abdomen, mouth, rectum, pelvic examination, cardiopulmonary system as well as general physical examination. Then we can go for lab tests such as complete blood count, LFT, kidney function test, ECG, chest x-ray, sugar, thyroid test, urine routine microscopy examination. In females, get done urinary SCG to rule out ectopic pregnancy. Bowel ischemia, look out for serum lactic acid levels. X-ray abdomen in erect position should be done. We can find multiple air fluid levels, especially in intestinal obstruction, as well as air below the diaphragm in cases of the perforation. Peptic ulcer disease, as we have already discussed, endoscopy is the gold standard. A small bowel obstruction, initially you can go for the X-ray, that is in erect position. Then you can also do other investigations such as ultrasound and you may get absence of the flatus, abdominal distension as well as increased bowel sounds. In gastroenteritis, we can get done CBC, stool routine microscopy as well as stool culture and sensitivity tests. Appendicitis is mainly clinical diagnosis. There is tenderness in McBurney's point. McBurney's point is the imaginary point which is there on imaginary line from anterior superior iliac spine to the umbilicus. There is 1/3 to 2/3 junction and there we can elicit the tenderness. In appendicitis, you can go for CT scan. The blood markers such as TLC and increased CRP is there. Pancreatitis, there is severe abdominal epigastric pain radiating to the back which gets increased on taking meals. Pain gets relieved on bending forwards. There is increased serum amylase lipase more than 3 times and you can confirm it by CT scans. Biliary colic pain is episodic from 30 minutes to hours. It increases on eating meals. There is a well-dictum fat, fertile female of the 40. There are more chances of gallbladder stones. We can confirm it by ultrasound. Acute cholecystitis, it is progressive pain which is occurring over the hours. Most common symptom being nausea and vomiting, also pain in right upper quadrant. It is second to again GB stones. There is a Murphy's sign in which you can find and you can elicit the right upper quadrant tenderness, especially on USG probe. That is a very specific sign for acute cholecystitis. Cholangitis, inflammation of the common bile duct. There might be right upper quadrant pain. Then there is progressive pain which is over hours, might be due to CBD stones, benign biliary structures and malignancies such as CA pancreas. There is triad of pain, fever and jaundice. Apart from that, there is shock in the cholangitis. There is decreased systolic pressure, increased heart rate, increased bilirubin, especially direct one, with raised alkaline phosphatase. You can evaluate cholangitis by CCT abdomen followed by MRCP, and therapeutic ERCP can be done in cholangitis. Acute hepatitis pain is progressive from hours to days. You can find jaundice in acute hepatitis, causes being virus, alcohol, then there are certain drugs and autoimmune. We can send the CBC, so there will be raised total leukocyte count, then LFT, like we can get increased SGOT and increased SGPT. They are sometimes more than 1000. Raised bilirubin, direct one is almost equal to the indirect with increased INR. We can send the viral serology, autoimmune workup, we can send the ANA levels. So surgical and abdomen might be there because of any kind of perforation, ruptured abdominal aortic aneurysm or acute appendicitis. Patient might land up in shock such as acute cholangitis due to bowel perforation, bowel infarction, ruptured ectopic pregnancy, ruptured abdominal aortic aneurysm. In case of acute MI as well as splenic rupture, there should be a systemic approach, step-up approach. Don't land up with advanced investigation in the initial stages. From clinical approach, you can go for basic investigations such as blood investigation followed by X-ray, ECG, ultrasound, and then further we can go for advanced testing such as CT, MRCP, and accordingly we can plan our management. If you have any queries, you can really ask. Thanks for watching.